we can. Yes, please try sharing again. Thank you, Professor.
Hello, and thank you for the opportunity to discuss unilateral cleft lip and nose repair.
Yes, you're welcome. Thank you, Professor Fisher.
I have nothing to disclose. I would like to acknowledge that cleft care requires a full team approach, and this talk represents just one plastic surgeon's thoughts. My time as a fellow with the Craniofacial Cleft team at Chang, I consider a pivotal time in my training. I'm very grateful for the teachings of Dr. Nordhoff, Dr. Yurei Chen, Dr. Leland Zhou, Dr. Philip Chen. This quote in Millard's Cleft Craft by Dr. Nordhoff nicely represents the ethos of the man and his program. Today, I want to present my protocol for care of patients with complete unilateral cleft lip and palate. I want to concentrate on the primary lip and nose repair, explain why I do what I do, highlight the advantages of the anatomic subunit approximation technique, and also advocate for a conservative primary rhinoplasty. My protocol for a child with a complete cleft lip and palate involves pre-surgical orthodontics in the form of nasoalveolar molding, which we initiate at 2 weeks up until lip repair, which is then performed generally between 3 and 5 months of age. I like to repair the palate at 11 to 14 months of age and perform a alveolar bone graft in a delayed fashion prior to eruption of the permanent canine at 8 to 12 years of age. There may be lip revisions, VPI correction, septorhinoplasty, and potentially orthognathic surgery at skeletal maturity. I no longer do the school-age lobule rhinoplasty, preferring to perform a definitive septorhinoplasty, ideally in the late teen years. I'm now starting my 23rd year of clinical practice at the Hospital for Sick Children in Toronto, and I'm approaching 3,000 cleft cases. The protocol that I've just outlined has been fairly consistent over this period of time with some minor changes. As mentioned, we start with pre-surgical orthodontics. It's not necessary, but I do think it is helpful. Dr. Bruno Venditelli is one of our orthodontists at the Hospital for Sick Children. He trained with Dr. Barry Grayson and introduced nasoalveolar molding to our program. And this is our preferred modality of pre-surgical orthodontics. I think the key component really is the alveolar molding. You can see the improvement in the nose in particular once the skeletal base is made more symmetric. I will first discuss the principles of unilateral cleft lip repair, and later in the talk we'll discuss rhinoplasty. The goal, of course, with a child with a cleft is to approach as normal a form and function as possible. We use the height of the non-cleft side lip as a reference for the medial lip element, which is universally short, and also for the lateral lip element, which varies in its dimensions relative to the non-cleft side. Dr. Hugh Thompson was a wonderful cleft surgeon at the Hospital for Sick Children. He wrote, "All cleft lip surgeons have their favorite surgical technique for repairing the unilateral cleft lip. It's usually a hybrid of training, experience, and imagination." The anatomical subunit approximation technique certainly derives influences from many of the previously described cleft lip repairs. I've been using it since January 2000 but published my initial experience with it in July 2005. In all cases, some lengthening is achieved by the Rose and Thompson principles. In most cases, a modified inferior triangle repair is also incorporated. The repair also utilizes Nordhoff's lateral vermilion flap, which is used to augment the vermilion height deficiency below the cleft side half of Cupid's bow. The lesser height C, or the base width of our inferior triangle, is calculated by subtracting the greater height B from the total lip height A, and also subtracting an additional 1 millimeter. The 1 millimeter accounts for the approximate lengthening achieved by the Rose-Thompson effect. It is important that these calculations allow us to mark the lip, but these markings are initial impressions which can be modified as we progress through the repair, provided we do the repair in the correct order. Today, I won't be going over every point in great detail. The details are well described in the initial publication in Plastic and Reconstructive Surgery. Here is an example case of a 4-month-old infant with a complete unilateral cleft lip and palate the morning of surgery following a course of presurgical nasoalveolar molding. These show typical surgical markings. The goal is to level Cupid's bow to bring the alar bases into a symmetric position from the anterior view, and to bring the lateral and medial lip elements together along the seams of anatomic subunits along a line which mimics the philtral column on the non-cleft side. I don't know how to make an appropriately dynamic functional philtral column. By that, I mean one that is present at rest, is more obvious with puckering, and is absent with mouth opening and smiling. My muscle repair is a simple end-to-end repair. The surgery is performed under a general anesthetic. I don't infiltrate the lip at all. I admit the patient for a night of overnight observation. I want the patient to be comfortable and drinking well before they go home, and I want the parents comfortable with suture line care. I'll bring the patient back 1 week later for suture removal, and then it's done under a short mask administered inhalation anesthetic. The Chang Gung repair, as many of you will know, is a modification of the Millard 1 repair. This is Millard's initial description, which was published in PRS in June 1960. It's a repair that is relatively simple to teach and learn. Millard described it as artistic rather than mathematical. And it's a cut-as-you-go type repair. I think the major disadvantage of all rotation advancement repairs is the requirement of compromise of Nordhoff's point. Not in all cases, but not infrequently. Dr. Ralph Millard wrote, "The advancement incision pairs the cleft edge. Some have considered the beginning of the full-bodied vermilion as a fixed point, beyond which pairing must not transgress." Now, I'm sure he was referencing Dr. Nordhoff. I marked the base of the philtral column on the cleft side lateral lip element according to the teachings that I learned in Taiwan, and I've coined this point Nordhoff's point. This point is marked on the vermilion cutaneous junction at a point where the vermilion mucosal junction, or Nordhoff's red line. Medial to this point, both the quality of the roll and the vermilion height diminish. Millard goes on to write in his description, actually, the pairing of the cleft edge on the lateral lip element must match the length of the rotation incision. This is problematic when the height of the lateral lip element is vertically short. And this is actually a very common finding in most cases of unilateral complete cleft lip and palate. In such cases, vertical height can only be accomplished by compromising Nordhoff's point and moving the base of the philtral column incision of the lateral lip element laterally. This has the effect of shortening the lateral lip element in the transverse dimension. Millard himself acknowledged this. When the lateral lip element is extremely small, there will be a shortness in the distance from the nasal floor to the commissure. Robert Poole from Michigan wrote, vertical height of the lateral lip element is difficult to obtain with the rotation advancement repair only when the lateral lip element is short in both its horizontal dimension and its vertical height. This begs the question, what is the frequency of this geometrically unfavorable lateral lip, one that's both short in its horizontal dimension and its vertical height? In this study published in PRS in 2011, we looked at our measurements taken from 100 consecutive patients with unilateral cleft lip. We looked at the lateral vertical heights and the transverse lengths using Nordhoff's point as the reference point on the lateral lip element. Each point in this scatter plot represents one patient. And we can see that in 63 patients out of 100, there was a combined height and length deficiency. So we conclude that the geometrically unfavorable lateral lip, one that's deficient in both lateral vertical height and transverse length, is a very common finding and is present in almost 2 out of every 3 unilateral clefts. Now, this study included all comers. It also included incomplete clefts, which tend to have tall lateral lip elements. So the majority of patients with a complete cleft will have one of these unfavorable conditions. When the lateral lip element is hypoplastic and extremely short in its vertical height, compromise of Nordhoff's point is unavoidable. Now, Dr. Nordhoff was aware of this. He wrote, it is seldom necessary to move this point, and if so, it's usually moved 1 or 2 millimeters laterally to increase the vertical length of the lip. Quoting Dr. Millard again, cleft surgeons must be perfectionists, free to aspire, willing to work in millimeters for the best possible result. And this compromise of Nordhoff's point, even if it's only a millimeter or 2, is a common requirement of all the variants of the rotation advancement type repairs. The problem is not simply that we're shortening the transverse length of the lateral lip element when it's already transversely short. The problem is that we have to discard the valuable tissue lateral to Nordhoff's point, which is that upward convexity, which if maintained will allow us to have a natural undulation of the upper lip after the repair. The anatomic subunit repair allows for preservation of Nordhoff's point in all cases, even when the cleft side lateral lip element is vertically short. In 1959, Randall described his modification of Tennyson's inferior triangle repair. This allowed for a smaller inferior triangle when compared to that of Tennyson. One advantage of the inferior triangle repairs is that it does not require compromise of Nordhoff's point. Triangulation with calipers can accommodate various vertical heights. So there is no need to compromise the position of Nordhoff's point. Additionally, under rotation is a rare complication. The disadvantage is a non-anatomic scar. As mentioned, the anatomic subunit repair derives influences from many previously described repairs. And I borrow Charles Tennyson's quote, "The author fully realizes that much of the operation is not new, and he is greatly indebted to previous technique, which will be quite obvious to any qualified observer." And it is also influenced by the subunit principle as described by Burgett and Menick for nasal reconstruction. In all cases, a Rose-Thompson lengthening effect is utilized. In most cases, a inferior triangle is required, as is the use of a Nordhoff triangle or lateral vermilion flap to augment the central vermilion deficiency below the cleft side half of Cupid's bow. It's extensile, and by that I mean it can be used in all cases of unilateral cleft lip. I've used it in every unilateral cleft in my career. We don't need to compromise in the position of Nordhoff's point, and therefore there's no need to sacrifice horizontal length to achieve vertical height. The repair can be used in all cases, regardless of the vertical height of the lateral lip element, allowing us to preserve that upward convexity of the lateral lip element required for a natural appearing lip. Approximation is made at the junction of anatomic subunits, positioning the vertical component of the cutaneous scar along a line symmetric with the non-cleft side philtral column. Similar to the molar repair, the line of repair is along an ideal line of repair mimicking the non-cleft side philtral column, ultimately being positioned in an intermediate position relative to the rotation advancement repair and the inferior triangle repair. The inferior triangle is small and occasionally unnecessary. In a consecutive series of 50 patients, the lesser height averaged 1.24 millimeters, ranging from 0 to 2 millimeters. Skin tension is optimally positioned above the roll, augmenting the pout of the lip. I think this is the ideal position for a small inferior triangle, as the cutaneous roll does not need to be augmented. And I prefer a simple end-to-end abutment of the roll elements so that there is minimal disruption of the light reflex off the cutaneous roll. Under rotation is a rare problem, particularly if the repair is performed in the right order. And by that, I mean performing the medial lip first. We want to level the bow and determine firstly whether a inferior triangle is required. And secondly, how large that inferior triangle need be to level the bow. We simply want to match the size of the triangular defect with the size of our inferior triangle. And finally, similar to inferior triangle repairs, there's no addition of scar at the nasal base. The medial point of closure in the nostril sill and the lateral point of closure in the nostril sill are determined similar to an inferior triangle repair. This avoids the complex arrangement of scars at the nasal base, as is described with Millard's second repair. Studies are now showing up in the literature comparing the subunit repair with Mollar's repair and with Millard's repair. There is also a study comparing the subunit repair with the Molar and the Millard repair. These three studies all favor the subunit repair. If you're thinking of trying this repair, or you've tried it and aren't completely happy with your results, let me give you some helpful hints. It's important that this operation is done in the right order. The initial markings are the starting point, and you don't have to commit to those markings necessarily. So the medial lip elements incisions should be done first. And I do the initial incisions with the exception of the back cut. I first want to test whether or not an inferior triangle is necessary. In minor clefts, lengthening may be sufficient by the Rose-Thompson effect on its own, and an inferior triangle may not be necessary. The next checkpoint is after the back cut is made. And as I showed in the short video, we want to level the bow and see the size of the triangular defect that's created by the back cut that has allowed us to achieve a level bow. And then we want to check our lateral lip markings and make sure that the triangle is that size. And at this point, we could change the size of that inferior triangle if need be. The third intraoperative checkpoint is the position of the lateral point of closure in the nostril sill relative to the medial point of closure in the nostril sill. And it's important to mobilize the lateral lip and nose elements sufficiently before committing to your lateral cutaneous incisions. So I want to ensure that the alar bases are symmetric from the anterior view and the nares are of equal circumference. I now want to address some common questions and comments. Firstly, I often hear, it appears that you discard a lot of tissue with this repair. Actually, the final scar is intermediate to that of a rotation advancement repair and an inferior triangle repair. So obviously the rotation advancement repair excises more medial lip tissue in the form of a C-flap, which was then introduced into the nostril floor. And the scar of the inferior triangle is more lateral, removing more tissue from the lateral lip element. And certainly we're not compromising on the transverse length of the repair, as we've mentioned, is required in many cases with the rotation advancement type repairs. How do you choose your 0.19? I don't, in fact, remember the numbers for each point. They're simply there for the description. But 0.19 is the lateral point of closure in the nostril sill. These points are chosen similar as one would choose when one performs an inferior triangle repair. We have a medial point of closure in the nostril sill. We have a lateral point of closure in the nostril sill. When they approximate, we want to achieve nares of equal circumference and symmetry of alar base position from the anterior view. So I usually pick the medial point of closure in the nostril sill along the lip columellar crease. That is chosen a distance away from the height of the philtral column incision that is really influenced by the vertical height of the lateral lip element. So the medial point of closure in the nostril sill will be further lateral in a incomplete case and more medial in a complete case. And this allows for the length of what I refer to as the third height. So the length of the incision line that goes from the height of the philtral column to the medial point of closure in the nostril sill, that length can vary and will take up more lateral lip height with a longer length of this incision when the lip is vertically long, as in an incomplete case. And we can take up less in a complete case when the lip is vertically short. So once that medial point of closure in the sill is chosen, I can then choose the lateral point of closure relative to it so that we've achieved those previously described goals. How are you able to keep the triangle so small? Firstly, the greater lip height is measured with the columellar base positioned in the midline and also with gentle downward traction on the lip to mimic the position of the lip at the end of the case. So this length will be longer in this repositioned position than it is at rest. The second important point is the appropriate positioning of the Cupid's bow peak. Now, I mark the Cupid's bow peak not at the high point of the upward convexity as most people might. Rather, I mark it where the straight part of the half bow meets the upward convexity of the lateral lip element. And the reason for that is that upward convexity is going to come from the lateral lip element lateral to Nordhaus point. It's not present in the medial lip element. The more lateral the Cupid's bow peak is positioned on the non-cleft side, the more cephalad will its partner be on the medial lip element. And this will require a greater amount of medial lip lengthening in order to level the bow, and thus will require a larger triangle. And finally, the height of the incision across the cutaneous roll needs to be tall. The taller it is, the more rotation will be gained by the Rose-Thompson lengthening effect. So I want to ensure that that length across the roll is across the entire height of that roll. I don't go beyond that, but I want it to be at least as thick as the roll. Do you use presurgical orthodontics? As mentioned, I do use presurgical orthodontics, but it's not entirely necessary. Certainly there are some cases where we aren't able to have that performed. And certainly if you don't have access to presurgical orthodontics, that doesn't mean that this repair can't be used. And probably the most common question, what about the nose? So I'd now like to discuss rhinoplasty. When I was a resident, McCarthy was the major reference text. And this is one of 4 pages showing previously described techniques to address the cleft lip nasal deformity. And when you have a number of techniques to address a problem, it usually points to the fact that the problem has yet been solved, and therefore there's been a lack of understanding. The cleft lip nasal deformity is largely due to asymmetry of the underlying skeletal nasal base. So it makes little sense to me that a primary rhinoplasty, which is essentially a soft tissue operation, alone could correct a deformity. My primary rhinoplasty is fairly aggressive at the level of the alar base, but conservative at the level of the nasal tip. It consists of a caudal septal repositioning, an alar base release, a lateral piriform release, internal nasal valve plication sutures, alar transfixion sutures, an anterior nasal floor and anterior palate closure, which we've termed foundation rhinoplasty, a columellar base, alar base cinch stitch, and I may use a nasal stent. I perform no dissection over the alar cartilages, and there are no skin incisions or excisions. Columellar base and alar base repositioning is in part dictated by the points of closure in the nostril sill at the height of the lip repair. It is important that before committing to the lateral point of closure in the nostril sill, that with that choice, we're able to accomplish alar base positioning that is symmetric from the anterior view and nares that are of equal circumference. The Millard 2 repair and the molar repair both introduce unnecessary excessive scarring at the base of the nose. The two main movements that occur with the lip repair are medialization of the columellar base and anterior repositioning of the cleft side alar base. When the columellar base is brought medial to the midline, if the caudal septum is visualized within the non-cleft side airway, that is my indication to perform a caudal septal repositioning. The caudal septum is released from its attachments to the primary palate and also from the mucoperichondrium on the non-cleft side. The caudal septum can then be brought into the vertical plane. This position will be maintained by virtue of its undisturbed attachment to the cleft side mucoperichondrium and the extended nostril sill closure. The alar base is released in a extra periosteal fashion, and this allows for the cleft side alar base to be brought forward to meet the medial lip element. But this is insufficient to correct the nasal deformity. In fact, the nasal deformity, the kink of the nostril margin and the flaring of the nasal ala are worsened by this maneuver. And this is because there still remains the attachment of the lower lateral cartilage, accessory cartilage complex to the piriform rim. This attachment to the piriform rim must be released, at least to the level of the inferior turbinate. Now, after sufficient release from the lateral piriform margin, the alar base can be approximated with the columellar base, and the nostril rim is now free to adopt a normal rounded shape. Harold McComb should be recognized for introducing primary cleft rhinoplasty. He argued that the lower lateral cartilage was caudally displaced in a bucket handle fashion and therefore developed a suspension suture to the nasal dorsum in the region of the radix. Well, in fact, the displacement of the dome is posterior and lateral. So the correct vector, or the ideal vector, is one that brings the cleft side dome anteriorly and medially. With the cleft side dome retracted anteromedially, internal nasal valve plication sutures are placed to recreate the normal overlap of the scroll area. Usually one or two of these sutures are placed. Alar transfixion sutures, similar to those described by Dr. Nordoff, usually one or two, are placed to lateralize the vestibular lining, so to prevent obstruction of the nostril. In cases of a complete unilateral cleft lip and palate, through the upper sulcus incision, the periosteum is incised along the piriform and cleft margin. This allows for subperiosteal mobilization of the nose from the internal skeleton. Inside the nose, the incision in yellow is taken along the cleft palate margin, and a back cut, shown in green, is made extending to the base of the inferior turbinate. The mucoperiosteum of the nasal wall is then advanced en bloc with the alar base, so that there is mucoperiosteum that now spans the gap between the piriform aperture and the new alar base position. This back cut in the lateral nasal wall lining allows for the cleft side alar base to be mobilized anteriorly. An extended nostril floor closure is then achieved, approximating the lateral nasal wall lining with the lining of the caudal septum. In minor clefts, a primary rhinoplasty may be all that is required. In more severe cases with significant skeletal asymmetries, some relapse is expected. In these cases, one can anticipate that a definitive septal rhinoplasty will be required in the future. Correction of the nose is never perfect in complete cases, but hopefully will be sufficient to avoid the need for further rhinoplasty until skeletal maturity. In my opinion, the best cleft rhinoplasty was described by John Potter in PRS in 1954. A intra-alar rim or infracartilaginous incision is continued laterally as far as the piriform margin, at which point a back cut is made in a intercartilaginous fashion. This allows for elevation of a caudal mucosal flap, which can then be advanced anteromedially in a VY fashion. This has the effect of elevating the dome and elevating the rim and lengthening the columella. And it can also be performed in a closed endonasal approach. I want to now share with you an example case, a patient who presented with an average cleft deformity, who had a fairly typical intervention as far as my protocol is concerned, and had what I would consider an average outcome. She underwent an anatomic subunit repair with primary rhinoplasty at age 5 months of age, and a hybrid palatoplasty with intravelar veloplasty at age 12 months of age. Here she is at 16 months of age, 6 years of age, and 8 years of age. She underwent a delayed secondary alveolar bone graft. The alveolar bone graft is really an opportunity not only to fill the alveolar gap to support the adult dentition, but it's also an opportunity to address the bony deficiencies in the region of the alar base and piriform margin. Here she is at 10 years of age after her alveolar bone graft. And we can see from the anteroinferior view that the alar base positions are symmetric in the AP plane. And here she is at 15 years of age at near skeletal maturity and wishing a definitive septal rhinoplasty. Since 2016, I've performed all of my cleft rhinoplasties in a closed or endonasal fashion. She underwent a septal repositioning, a Potter type VY advancement of the lower lateral cartilage as a chondromucosal flap, dome defining sutures, a columellar strut, and a tip shield graft. She declined osteotomies to narrow the bony pyramid, so this was not performed. Here are pre and postoperative views from the anterior view, the lateral view, and the antero-inferior view. I now have over 200 patients for whom I have performed their primary surgery that are now 17 years of age or older. And only 20% of these patients, 16% of unilateral cases, have elected to undergo secondary rhinoplasty. The reason for this is multifactorial. However, my point is that at least some of my patients are happy enough with their current appearance. I'd like to conclude my talk with reminding everyone that we are in the first do no harm business. In my opinion, the primary lip repair is not the time to be performing skin excisions or incisions. Indeed, I don't think skin excisions or incisions of the nasal envelope are ever necessary. I don't want to introduce an iatrogenic deformity that in the future I won't be able to fix. Thank you again for your invitation. Thank you for your attention. And I'm happy to stick around and answer as many questions as I can given the remaining time available.
Thank you so much, Professor Fisher, for the very comprehensive lecture. Now, before we move on to the Q&A, we would like to invite our panelists for some comments. First, we would like to start off with Dr. Liu.
Thank you, Dr. Fisher, because when I come back from CKIS, I try to use your technique, and I attend 2 courses of the study section in ACPA by Raymond. And I think this talk is very good because I finally understand some small technique from your talk. So thank you very much.
You're welcome.
Next, we would like to invite Dr. Frank Chang.
Yeah, I think Frank is not here.
Oh, okay.
Yeah. Mhm.
Then I guess we'll go straight to Professor Low. Professor.
Hi, David. It is nice to hear from you. And it's a very nice presentation as well. I think my technique of lip repair is basically very similar to yours, but my skin incision still remain in the white skin row. Okay, but I focus more on muscle dissection, muscle repair, and I believe that skin will follow the muscle. Now, when I repair the muscle and I approximate the skin, if there is any skin excess, I will excise the skin. I know you directly make incision away from the white skin row, so that's why people question, oh, you seems that you excise some of the skin component. So as I learned from Dr. Nordhoff, my skin incision remain in the white skin row. So this is my first question. Second is that regarding the complete and incomplete, do you use the same design? There's no change, whether the unilateral is complete or incomplete. Finally, still very happy and enjoy your talk.
Thank you. Thank you very much. So I'll answer your second question first. So
the markings on the medial lip element are fairly consistent through all comers, with the exception that in minor cases we may not need the back cut to level the bow. The differences will be mainly in the lateral lip element, which varies in its vertical height. And so between our lateral point of closure in the sill and our point above Nordhoff's point above the roll, that height can vary and will vary. So in a incomplete case, I'll make, as I mentioned, the third height, that length from the height of the philtral column to our medial point of closure in the sill. We can change the length of that so that in a incomplete case, we'll make it longer so that on the lateral lip element, we can take up more vertical height. Conversely, in a complete case where the lateral lip element is vertically short, I'll make that third height shorter. And that will allow me to take up less vertical height of the lateral lip element in the repair. So I think the nice thing about this repair is that it can accommodate all lateral lip element vertical heights. And that's really not a consideration for the rotation advancement type repairs. I'm not sure I understood your first question.
The skin incision.
Yes.
You make skin incision away from the medial incision, lateral incision, both away from the wide skin row, right?
Well, they both cross the cutaneous roll in a
Close to
perpendicular.
cutaneous row. Yeah.
They cross it in a perpendicular fashion, and the back cut and the inferior triangle are above the roll. So the roll elements come together in a end-to-end fashion. I remember when I was in Taiwan, watching the Chang Gung repair. Initially, the incision was made across, and the medial lip element across the roll in a similar fashion that I do. But at the very end, that little extra bit was snipped off. But you know, if you and also the other issue was sort of a modified Millard 1 repair was performed, and if it was short, then you would pair off a triangle from the lateral lip elements and put it above the roll. So our triangles are placed in the same spot. The differences are, if you maintain that little bit of tissue in the medial lip element, instead of snipping it off, it can give you some length, and that's the Rose-Thompson lengthening. And then if you commit to an inferior triangle above the roll initially, then you don't need a rotation incision. So this is the you know, those are the sort of evolutions. When I started, I did it was basically a combination of what I learned in Toronto from Dr. Hugh Thompson and what I learned from yourselves at Chang Gung. It was a combination of the two. And I really think that, so much of what I do, I learned in Taiwan. And, I'm deeply indebted to my time there. I think it was one of the most important 6 months of my life, I have to say.
Yeah. I still remember that you and me and sitting in front of the computer, looking at the 3D, image, looking at the piriform margin, doing the measurement. That's quite, very nice memory. Now, David, can I still discuss with you the primary rhinoplasty? You know that first, Dr. Nordhoff told us to do inferior dissection through the columella, through the alar base, the whole around of the alar rim. And then this is basically intranasal dissection and approximate the two lateral, low lateral cartilage. And then I did that for several years. Then I found that in many of my patients still complain the nasal tip definition is not good enough. Still see separation of the low lateral cartilage at the tip area. And then I changed to do Tajima approach, which is skin incision outside the nostril, and then do the dissection. And when the low lateral cartilage is released, the skin will move inside the nostril and suture. And we found that this nasal tip from this approach, the nasal tip definition is much better, and we intentionally do overcorrection, and we found that this nose tip definition and also the columella symmetry is much better. So right now, I routinely do this Tajima approach. Actually, I think the Chang team pretty much, maybe Tinchen and also Frank also do this Tajima approach for the primary rhinoplasty. Can you comment on this?
Yeah. So the issue with the Tajima, well, first of all, at least in my hands, I don't think I'm able to reposition the cleft side dome perfectly in a primary case. I think, and I think the cartilages are so weak that the tension of the skin envelope and the residual asymmetry of the skeleton are the greater factors. And so that I don't think I'm able to correct it completely in a primary case. So I don't want to add additional scar. My principle is I want to do something that makes sense, and I want to do something that's effective. And I'm not sure in my hands I'm effective enough in doing that. So that's why I don't really try to reposition the dome more than what I showed you with those internal nasal valve plication sutures, which I admit are not long term. But my hope is that it leaves the cartilages in a better position than if I hadn't done them. As far as the Tajima goes, the issue I've had with it is if you do a Potter rhinoplasty, then what you're doing is you're not only moving the cleft side dome anteromedially to a better position, you're also moving the lining. And that lining will raise the rim when you close it. All right, because you make a rim incision, and no matter what you do above it, if you leave the lining where it is, everything is going to come back down where it was. But if you can move the lining anteriorly, then the closure will be more anterior and the rim will come forward. So that's, in my mind, the advantage of the Potter. What the Tajima does, in my understanding, is it rolls the lining of the soft triangle inward. So,
yes.
And so instead of doing this, you're doing this, or the other way around. You're rolling the lining inward.
Yeah, just inside. Yeah.
Right. Yeah. So moving it inward. So you're, in a sense, taking away soft triangle and
Yes.
repositioning it internally, as opposed to bringing it into a more natural position. So just fundamentally, I think in my mind, the Potter makes more sense to me. But I probably have, I will acknowledge that I'm sure your noses are better than mine, but that's what I do.
Well, thank you for your comment. Yeah.
Okay, so at this time, I guess we'll go straight to Q&A, if that's okay with you, Professor Fisher.
Yeah, of course.
Okay, so first we have a question from Dr. Camwell, and he he wants to ask if you may please expand a little on how you on your technique for nasal floor repairment.
Right. So it's described in recently in PRS. If you look on the first author is TSE, Raymond J. And there's a more detailed description of it there than what I was able to give you today. But the nostril sill closure really is an extended nostril floor closure. So it extends in the caudal septum, probably about 12 to 15 millimeters intranasally. And then the incision along the palate cleft margin continues that same length, and a back cut is made in the lateral nasal wall, lateral to the inferior turbinate. And that allows the alar base and the lateral nasal lining to come forward. So the main movements, as I mentioned, are the medialization of the septum and columnar base on the greater segment, and anterior movement of the alar base on the lateral segment. So the cleft marginal incision and the caudal septal incision approximate together to give us our extended nostril sill closure.
And for our next question, we have Dr. Koslin. I'm sorry if I butchered your name, but what is your protocol for postoperative care to minimize the scarring?
Right. So I use permanent sutures so that there's less tissue reaction. I usually only use 1 or 2 deep dermal sutures, again, to reduce the likelihood or reduce the potential for stitch abscess, and also to reduce tissue reaction. Have them come back at a week to have those stitches removed, and that way I can ensure that one, that if I use permanent sutures, then I know that the stitches can be cleaned without the risk of them dissolving too early. We can control the timing that they are removed, so they come out at 7 days, not earlier, and with partial dehiscencies, and not too late with additional scarring and the sequelae of pitting and dotting along the cleft or the scar margins. You know, I always say this is cosmetic surgery for me. I don't have a cosmetic practice. I don't think anyone would put dissolving you know, chromic stitches or glue on a cosmetic blepharoplasty case. We use permanent sutures for a reason, and the reason, I think, is we get better scars. And then I have them come back 2 weeks after the suture removal, so 3 weeks after the original surgery, and I'll teach them scar massage. I have them massage and massage and massage and massage. I tell them they can't overdo it. The more they do it, the better. And I want them to continue that until the scar is soft, flat, and pale. And I just have them use Vaseline. I don't, they always question whether there's some magic potion. I think time and massage are the key factors. And I just want something that is a lubricant that is inexpensive and not poisonous.
And next question is from Dr. Crescenti. And the question is, in cases where you don't use NAM, were you able to correct the nose without primary rhinoplasty?
So in all cases, in my mind, I'm able to get some improvement. I'm never able to correct it completely with the primary rhinoplasty that I do, unless it's a minor case. The issue in cases where there's no alveolar molding is that the greater and lesser segments or there's going to be a large AP discrepancy. So I don't really care how wide the cleft is from a medial to lateral standpoint, because those tissues are elastic and they can easily move together. It's the AP discrepancy that's the problem. The lateral lip element has to do all the movement anteriorly. And if there's no skeletal base symmetry, then it's going to fall back to some extent. And the degree of relapse, I think, is going to be dictated by that AP discrepancy that we're left with. And part of that is not only part of that is not only displacement of parts, but it's also hypoplasia. So we know that in a cleft, we've got deficiency in the region of the alar base and piriform rim. And the more deficiency there is, the greater the residual skeletal asymmetry will be, whether or not you're able to correct it to some degree with alveolar molding. So I think the goal really should be to get those segments in better alignment in the AP plane. And if we're able to do that, then I think there'll be less relapse afterwards.
Okay, our next question is from Dr. Honda, and he would like to ask you, how do you fix the repositioned caudal edge of the septal cartilage during the primary lip surgery?
All right, so I keep the mucoperichondrium on the cleft side attached to the septum, and I detach it from the mucoperichondrium on the non-cleft side. So that cuff of nasal lining below the septum is a continuation of our nostril sill closure. And so by virtue of its maintained attachment to the non-cleft side septal mucoperichondrium, it brings the septum to the vertical plane. Often in a severe cleft, the anterior nasal spine is displaced laterally to the non-cleft side. So securing it to that it doesn't make much sense, because that's too far over to the non-cleft side. So if you leave it attached to the soft tissues on the cleft side, then the closure itself will gently reposition the septum in the midline. There's often no bony, there's often no skeletal structure to secure it to.
And our next question is from Dr. O. He would like to ask, in cases of geometrically unfavorable lip, the lateral lip length sacrificed to match the vertical lip height matching is caught up after several years. I guess I think what he means is that perhaps maybe due to the age difference, maybe there's a difference in the vertical lip height versus the caudal lip height. I'm not sure if this is.
I mean, there's some people who believe that the length of the lateral lip element lengthens after the repair with time. I don't agree with that. I've certainly seen short lateral lips, and in my practice, if they start with the short lateral lip element, the transverse dimension. I don't know how to lengthen that, but I make sure that I don't compromise on it anymore. And so if it's transversely short initially, I think it's minimally improved afterwards with growth and time. I know there've been some papers that have described that there's been some lengthening, but I think the two papers that I'm thinking of are both flawed. And I don't agree. I don't think that's a real entity in my observation.
And for our last question, Dr. Kulabi would like to ask you, is there a benefit for the turbinate flap to support the ala base for, in order to reach a level of symmetry?
Yeah, so I used to use a turbinate. I learned the turbinate flap in Taiwan, and I did that initially for many years until I sort of came upon a more extended nostril sill closure, which I thought was probably more effective. But I don't have any evidence to show that yet. But the reason I moved away from the turbinate flap was because I wanted something that was going to be more universally applicable. And in my experience, the issue with the turbinate flap is in narrow clefts, it's hard to raise. In lesser clefts, there's almost no point in raising it. When you have a very wide cleft, the turbinate flap may not be large enough to cover the gap. So, like I said, so it ended up being, for complete cases, I might use it in that middle half of patients. And with the really narrow ones or the really wide ones, it wasn't helpful. So, like I said, I wanted something that was going to be more universal, and I think this foundation rhinoplasty is working well for me at the moment.
Yes, thank you, Professor Fishers. I think that we have a lot of more questions who want to be answered by you for a so comprehensive talk today. We cannot stop the entrance of all the questions from our participant. They are so enthusiastic, just like your talk. But I think today is a very unforgettable and very pleasurable. So I would like to invite all of our participants here to show your face and your beautiful smile with us and with the Professor Fisher together to have a group photo, because today is a very wonderful day. It's our first meeting online in 2022. We are so lucky and we are so honored with Professor Fisher. So I will count to 3. Would you like to say cheese and with a beautiful smile, and we can have a photo together. Thank you very much. So, okay, let's start. 1, 2, cheese. Yes, and probably you can show your sign. You can show your heart or you can show your thumb, please. Okay, 1, 2, cheese. Okay, let's turn to the next page. Yeah. Okay, please show your smile with us. Okay, 1, 2, cheese. Thank you. Yes. And I would like to go to the next page. Yeah. 1, 2, cheese. Okay, thank you very much for your warmly and a very beautiful smile. Finally, I have a conclusion is that for the topic today is talking about cleft surgery. As you know, my friend we have annually Chang's Forums meeting. This year, our topic is about Cleft as well. It's a biannual topic in Chang'an Memorial Hospital, the Craniofacial team. I have to introduce and promote. Please give me 2 minutes. This year, the 12th International Workshop in Cleft, Lip, and the Palate. I think today the format is the same, like the webinar online because of the COVID. Yeah, so the date of the Chang'an Forum this year will be located in October 29th and to October 30th. We have 2 days the webinar programs. We were talking about the unilateral cleft, lip, and palate with the video demonstration by the Millard, Moller, and Professor Fisher's method, and followed by bilateral cleft, lip, and repair with video demonstration. And then we will introduce the Palatoplasty, speech assessment, and the recommendation for this problem. The other days, the program will going on with the topic of the nasal alveolar molding and the alveolar bone grafting. And then is the Cleft OGS with the video demonstration. And followed by the secondary cleft lip and the nose revision. And the last program is the microscope reconstruction and the hemifacial microsomia reconstruction as well. Thank you again, and looking forward to your join and participation in this year's the Chang'an Forum. Thank you, Professor Fisher, again for your very great, wonderful topic for all these lovely participants here for about 90 minutes speech. I have to say sorry, the technical error in the very first beginning. Everybody can hear Professor Fisher's voice, but Professor Fisher cannot hear any of us the voice. But no doubt today is worthy for waiting, and we are so lucky. Thank you again. See you. Good morning and good night. Bye bye.
Well, thank you. Yeah, thank you very much. I'm sure that the technical problem was on my end, so I apologize, but
not really. Yeah.
Great to see you all. I really appreciate you. Thank you.
Yeah. Thank you.
Thank you.
Bye.
You.
Bye-bye.
Bye-bye.
Bye.